taking place here at Heritage Christian University from the 22nd to the 24th of May 2025. Heritage is very pleased to partner the International Healthcare Foundation and the African Christian Hospitals from the USA to hold this year's Medical Missions Seminar. And admission is free. I encourage you to register now and be a part of the team of medical professionals who are going to be here for this very insightful Medical Mission Seminar. Come and network, come and be equipped with more skills so that you can also undertake medical missions. You're welcome to the campus of Heritage Christian University.
And destroy. I have joy, I have joy in my heart, deep down. Oh, Jesus gave to me, Jesus gave to me, and no one can destroy. I have joy, I have joy in my heart, deep down in my heart. Let's kindly take our seats.
Thank you, Onesimus, and welcome back. All right, so we'll have the next keynote, and then after that we'll have the final breakout session, then we'll call it a day. So we'll be listening to a presentation on the need for surgical care for the poor, and this will be delivered by Dr. M.M. Apanudo. She is a pediatric surgeon at the Nigerian Christian Hospital, and she earned her medical degree in 1996. After her housemanship and compulsory national service, she worked as a general practitioner for several years before starting her surgical residency in 2007. Now, she has decided to get into pediatric surgery because there is a shortage of pediatric surgeons in Nigeria, and she realized that using her medical skills to care for children is something that she needed to do. And so she will come and then let us know more about her field and how we can also use that in the mission work of God. Please help me welcome Dr. M.M. Akpanudo.
Okay, nice working. Thank you. Okay. Good afternoon, ladies and gentlemen. Thank you so much for that very warm welcome. I was wondering, is it me that they were clapping like this for? That's for me. Thank you so much. It's an honor to be asked to give another keynote lecture at the Medical Mission Seminar. This time, I'm grateful that we are in the very warm climate of Ghana. And so this is much more favorable for me. This is actually my second time coming to Ghana. The first time I came to Ghana was in 2014. Then we went to Kumasi. That was where Kumasi hosted the annual scientific conference of the West African College of Surgeons. And it was a pleasant experience, but I experienced this cultural shock. And you might wonder why a culture shock. I mean, we're next door neighbors, right? We are West African siblings. So our cultures are supposed to be sort of the same, but that wasn't my experience. I remember when I went back home and I was telling my colleagues, you know, the people in Ghana actually obey traffic lights. In Nigeria, nobody has time to be nice like that. The light is red, you keep going. You just wiggle around and just be sure that nobody hits your car. Then you're good, you keep going. And then also, I remember there's another thing, like you guys have never heard of African time. It's an African thing. So when I came, at the conference in 2014, they gave us this program that everything, first session would start at 8 o'clock in the morning. Of course, my internal Nigerian clock told me that's probably 10 o'clock. So I was so proud of myself when at 8:30, I was leaving my hotel room, thinking I'm going to be the first person there, only to get there and they finished the first session. So, like I said, it was a culture shock, and I just had to adapt accordingly. But I'm grateful to be back in Ghana, this time not as a visitor, but this time as a partner in the work we're doing. Now, I have been associated with the African Christian Healthcare for a long time. Like I was introduced since in the 90s when I was a medical student. That's when I started going to disturb Dr. Whitaker to please teach me the ropes about, even as a medical student, what it means to be a good doctor. I'm here today as one of the representatives of Nigerian Christian Hospital. I actually have other jobs. I'm a lecturer in the medical school at Uyo, a pediatric surgeon at the University of Uyo Teaching Hospital, and I'm also with the Abong University Medical Center. But my capacity today is with the Nigerian Christian Hospital. It's a small hospital in the southeastern region of Nigeria. It was started in 1965 by Dr. Henry Farah, with the help of the local community. And from there, that is where the African Christian Healthcare Network sprouted up, and it has grown to involve other African countries and even missions around the world. Earlier this year, I had the privilege to attend a similar seminar like this, medical mission seminar in the United States. And I was deeply moved by the stories of how that that humble beginning has spread to stories of Christ healing missions around the world. And I count it as a privilege to be one of them. Okay, sorry, this is a picture of the hospital. Don't mind how small it looks. It's actually bigger than that. Just the picture is quite deceptive, So we have maybe 150 beds plus or minus, Let's not go into details. Now, when I first got the email from Brother Dofo that I was assigned this topic, the need for surgical care for the poor, I assumed it was going to be a very straightforward topic, It sounds like something that when you want to discuss technical or policy, like a policy-driven discussion. So I imagine that when I will come out here, I will come and start quoting healthcare statistics. I will tell you about healthcare financing. I will tell you about WHO benchmarks. But I soon realized that message may not actually be complete. I actually appreciate the president's speech this morning. It seems like what I'm going to say and what he said they're actually aligned. I don't know who copied who, but I just want to believe that maybe the Holy Spirit is actually directing the direction, of this presentation. So around the time I got that email, I was called to see a very sick patient, a 4-year-old child. Now, I'm somebody, I don't know whether it's the African in me, but I don't just take things for granted. I must see a sign in everything. Something happens, I want to know, is God trying to tell me something? I don't think things just happen coincidentally. So I think that at the time I got this email, I saw this 4-year-old child. He presented with what we call an intussusception. Now, intussusception, for those of us who are not medical, it just means that the child's intestine has invaginated. I don't know, it's better seen than imagined, but imagine that the intestine has invaginated. Okay, for my African sisters, when we kill chicken, right? You want to wash the people eat the intestine here. Sorry, in Nigeria we eat the okay, yeah, sorry. So when we want to wash the intestine, you know how you put a stick and turn it inside out? Yeah, so that's what happens with intussusception. It invaginates on itself. Now, there's nothing particular about intussusception. It's a very common cause of intestinal obstruction in children. I see them 1 or 2 every week. But what struck me about this child was, like I said, he was very sick. He had been sick for 3 weeks. He came, he was, just bones with a layer of skin. He had not eaten in that 3 weeks. Not because they didn't have food, but because, he was unable. He had intestinal obstruction. And what made it worse, that intussusception had progressed. It kept moving down distally until it finally came out of his anus. And when he came out, he had already lost his blood supply, so he was gangrenous. I don't know what kept that child alive up till that time. So, but when I told, the father came with the mother and the boy, and I told the father, "Sir, your child needs surgery." And he looked at me and he shook his head, because they have already tried other places. We were their last resort. He shook his head and said he does not have money for operation. He had hoped we would just push the thing back inside, give the child drugs so that the child can start eating again. I said, no, it doesn't work that way. We have to operate. He was reluctant, so after we reassured him, don't worry, we'll go ahead and do the surgery, that maybe afterwards you can now sort out the finances later. He reluctantly agreed. Then he promptly left. He left his wife and the child there for us in the hospital. Maybe he had to go back to work or something, but he left. And we didn't see him again until many weeks after the child had been discharged. Now, so we had to give his wife money for food, everything, all the things she needed. And as a side note to the young ones who have not decided what area you want to specialize in, if you're thinking of making money, pediatric surgery is not the way. Because your salary will just go like this. So we tried our best to support the child. The child started gaining weight. It was fine. But around that same time, now all these are happening, these events are all happening, and I say they're not coincidental. I can't remember, but I was reading, I have this app that gives me the verse of the day and so on. And I came across this verse that said in Proverbs, that's the verse on display there. Proverbs 14 verse 31 is the last part that struck me. But whoever is kind to the needy honors God. Whoever is kind to the needy honors God. And it struck me, maybe the sign that God was trying to give me was this child. At that moment, it was no longer about a child with intestinal obstruction. It was now about honoring God through how we treat a poor patient. You see, I've worked for years in surgery. Like as I was introduced, I've been a surgeon for many years. I've worked in public health. I do have a degree in public health, and I'm working on my PhD now. And I've also worked in medical missions. And I've seen poverty up close. I have done many surgeries, simple ones, complex ones, for people who can afford, and mainly for those who could never afford their care. Yet despite this, I had never stopped to intentionally ask myself, what does the Bible say about poor people? What does it mean to me, not just as a surgeon, but as a Christian? I mean, caring for poor people is essential to what we do. But the problem is that if after all our efforts, after the volunteering, after all the donations, after all the mission trips, if we lose sight of the people behind the poverty, then we have lost the heart of God. So let's look at what it means to be poor briefly. Now, poverty is a very complex and multi-layered experience. The Bible often describes people who are poor with different characteristics, such as needy, they lack food, they cannot afford things, they cannot support themselves, they wear shabby clothes, they're naked, they're full of wounds, etc., etc. While I know there's some verses that talk about poverty metaphorically, like when Jesus was talking about, in Matthew chapter 5, about people who are poor in spirit. But the majority of times, the Bible refers to poverty as material poverty. And there are not a few. Now, one global benchmark that I came across puts the poverty line at $6.85. Now, I don't know where they measure that line from, because when I now converted that to Nigerian Naira, I now realize that as a lecturer in the medical school, that looking at my payslip, I'm very close to poverty. And that's just based on what I receive every month. But poverty is not just about income. It's about lacking resources that the patients need to survive, to thrive, and to participate in society with dignity. People experience poverty differently, as you can see from the slide above. But it always involves a common element of material insufficiency, vulnerability, and then often there's also associated silent suffering. So if I were to reframe the question, yet again, the question now becomes, why must we, as Christian health workers, care about poverty at all? What makes this thing poverty as a surgeon? What makes it my burden? What makes it my calling? So that is the question we're going to work with now. Well, the first reason, I found for why this is our burden is because God cares deeply for poor people. It's actually a biblical mandate. You see, the word poor appears nearly 200 times in the Bible. But don't worry, we're just going to read about 100, maybe not more than 100 of them. So, in Deuteronomy 15, verse 7 to 11, God gives Israel clear instructions. And to paraphrase, he says, if there is among you a poor man, one of your brethren, you shall not harden your heart or shut your hand, but you shall lend him sufficient for his need. You will give him freely. And it all goes on to say, for the poor will never cease out of the land. Also in Proverbs 19, verse 17 says, he who is kind to the poor lends to the Lord, and the Lord will repay him for his deed. And of course, we all know when Jesus was announcing his ministry in Luke chapter 4, verse 18, he said that the Spirit of the Lord is upon me, and he has anointed me to preach the good news to the poor. He went on to say that he's here to bring salvation, lift burdens, bring healing, and to touch those who have been otherwise oppressed, to restore dignity. Now, the one I like most is Galatians chapter 2, verse 10. In this place, Paul was recounting his experience at the conference in Antioch. So he said that after he had made his presentation to the Jewish the Jewish apostles, they told him, your ministry is fine. Go ahead, continue preaching the gospel the way you're preaching it. We are not going to change anything in what you're preaching. The only thing we're asking for is that you remember the poor. And Paul goes on to say, this is the very thing which I was eager to do. You see, the thing about this particular verse is that it brings into focus poverty together with what? The gospel. So that tells us that as Christians, if we're going to hold on to the truth of the gospel, we must also not do what? We must not forget the poor, or the people who are poor. Because if we forget people who are poor, then something is lost in our preaching. Our preaching is not complete. Another reason why this is our burden, because true worship, if we're true worshipers of God, it requires justice. Now, earlier this year, I came across Isaiah 58. It has become one of my favorite chapters in the Bible, and I keep referring back to it. It's often read during times of fasting. I'm sure we all know it as the fasting chapter. It's especially connected with the Jewish, is it a holiday? Of the Yom Kippur. Now, that's the Jewish Day of Atonement. So what happens once a year, the people will gather together and the priests would offer sacrifices for their sins. Now, during that time, the people would fast and they would humble themselves. Now, in verse 3, the people complained, why have we fasted and you have not seen? Why have we humbled ourselves and yet you take no knowledge of it? Well, God responded. In verse 6 to 7, he showed them that there was a disconnect between their ritual and their daily behavior. He showed them what true worship looks like. He said, is this not the fast that I choose? To loose bonds of wickedness, to let the oppressed go free. I'm paraphrasing now. Is it not to share your bread with the hungry and to bring the homeless poor into your homes and not to hide your face from your own flesh? So God is saying, if you want to please me, you have to care for the afflicted, you feed the hungry, you welcome the homeless, and you stop turning your face away. You see, true worship according to God involves justice, not just sacrifice. Compassion. We've been saying compassion all day, and I'm going to continue saying compassion. Compassion, and not just ceremony. That portion shows us that faithful worship always leads to faithful action. If we are truly walking with God, then we have to walk towards the people who are poor. We have to walk towards people who are oppressed. We have to walk towards people who are hungry and those who don't have a voice. You see, the reason why a lot of communities are underserved, why is there poverty? Why is there marginalization? Why is there health inequity? All these things are not just merely public health issues. They're not merely economic issues. They're actual moral issues. They're the result of what? Injustice. So in our own small way, when we step in to serve in these missions, we're trying to restore and we're trying to uplift the community. In our own little way, we fill in that gap for those we stand in the gap for those who are afflicted. If you read Proverbs 31, 8-9, God reminds us that we need to speak up for those who cannot speak for themselves. We must defend the rights of the poor and the needy. In 1947, there was this author, Carl F. H. Henry. He wrote this book, The Uneasy Conscience of Modern Fundamentalism. Now in this book, he tried to warn modern Christians that the church was in danger of withdrawing from social and moral issues in their communities. He said that Christians were becoming, and this also affects me, he said Christians were becoming too focused on their personal piety and their doctrinal precision, while ignoring the suffering around them. He believes, and I believe, that Christian conviction must be always matched by Christian compassion. So it's very entirely possible for us to go to church every Sunday. We attend worship. We dot all our I's and cross all our religious T's and make sure that everything is, we don't go beyond the scripture and we don't take away from the scripture, etc., etc. But if we hold an attitude towards people who are poor that separates what we do from the heart of God, then we've missed the whole point. We have missed the whole point. If our religion is self-centered, then it only concerns us, then like what God was saying in Isaiah 58, he's not interested. The next reason is because we are all made in the image of God. Now I'm going back to Isaiah 58 again. There's so much resource and so many resources there. In the last line of verse 7, God says, do not hide yourself from your own flesh. Now there were some translations that I saw that was saying, okay, this is probably referring to our relatives. But I don't think so. Because even back then, if you read the book of Deuteronomy, you know that the Jewish people took care of their own. Read the Old Testament. Just like we take care of our own people, our own relatives. So I don't think Isaiah or God was trying to tell them, please go and take care of your cousins. No. He was telling them to recognize our shared humanity with people who are poor. They are our own flesh. So he was saying, don't turn away from people who may look different from you, who may suffer differently from you, who may live differently from you. See them as your own, as one of you, because they are what? They are one of us. So it's not our place, I think it was Dr. Shannon was saying this morning, it's not our place to judge why this person is here, why he's in the situation he is. It's not our place to say that it's their fault that they're poor, or is their fault that they're sick? Because they were not adherent, they didn't listen to everything that they were told to do. It doesn't matter whether they made mistakes, whether they followed bad advice, or whether they just ran out of options. Our calling is to meet them in whatever situation that they're in. We have to make sure that we restore them back to a place of dignity. So they're not just our patients, they're our brothers and our sisters. They're also image bearers with Christ. The Bible reminds us in Proverbs 22, verse 2, that the rich and the poor have the one thing in common. The Lord is the maker of them all. Now, the last reason why we need to take up this call to treat the poor is because the need is great. So why do we need to include a surgeon in every trip? Why is it important that surgical care be part of the conversations when we're discussing the ministry to the poor? Because the need is immense. The surgical need is immense. So now let's look at the statistics that we've been dodging all this while. Recent estimates suggest that 30% of the global disease will require surgical intervention at some point. So if all the diseases, we take 1/3 that will require surgery, that's actually a very, very big number, and it highlights how essential surgery is. But globally, we have 5 billion people who don't have access to good surgical care. And of all these procedures that are done worldwide, only 6.3% are done in the poorest parts of the world. Now in the population, in Nigeria with a population of over 200 million, don't mind us, we stopped counting at 200. I don't know how many we are right now. We are numberless, We're just millions of people. But, the need is even more acute. We carry nearly 22%. That's our number. We're like almost a quarter of this population of sub-Saharan Africa. But we only have 3.7% of the surgical workforce. There was one estimate a few years ago that said that Nigeria has about 1.65 surgeons per 100,000 people in the population, as compared to the recommendation of 20. And maybe I should say we had, because the brain drain has been so devastating. I don't know if you even have half a surgeon left, to per 100,000 patients. Now, but let me jump to pediatric surgery. So when it comes to pediatric surgery, the numbers are even more dire. At that time, we were like less than 0.14 pediatric surgeon. That's less than a quarter of a pediatric surgeon that can attend to 100,000 children in the population. So in real terms, that means that up to 98% of the children who require surgical intervention will not be able to access it within that 2-hour critical period. And a lot of these times, that 2-hour critical period is what defines the difference between life and death. And I saw similar statistics from Ghana and other sub-Saharan African countries. It just shows that there's a great unmet surgical need, with actual surgical volumes falling well below global benchmarks. But beyond, I'm sorry, this is quite small. I don't know if you can see that. Beyond these statistics, there are actually lives that are affected. The shortage has real human consequences. We have people who die from things that could have easily been treated. I've seen a patient brought in at the point of death from a hernia, that had been obstructed and so on. That child I told you about earlier would have probably died if for something as simple and as common as interception that we see all the time. We see women who lose their lives, lose their babies because they couldn't get access to obstetric care. Others are left with chronic pain and disability from poorly treated injuries. We have seen Dr. Benskin share some stories with us this morning, some with bone infections and congenital abnormalities. We have people who are blind, who may never see again. Why? Because they can't get access to cataract surgery. We have children with bizarre congenital abnormalities. We have women with obstetric fistulas like the VVF who live in isolation and are stigmatized. Why? Because they can't get access to surgical care. We have cancer patients who endure undignified suffering because they present late or because they couldn't get access to care. And then we're not even talking about the economic toll. The Lancet Commission projects that in low and middle income countries that we could face up to trillion of GDP loss if surgical needs remain unmet. Now, these numbers are not just abstract. These economic numbers have real impact. It means that children who have their food pulled off their tables, there are children who are pulled out of school because they have to go and work or they have to take care of their relatives. There are families who spiral deeper and deeper into poverty with each medical crisis. Why? Because we were not able to provide essential, cost-effective surgery. And then we must also acknowledge the emotional and spiritual toll. The mental health impact is something we really can't measure. The depression, anxiety, the uncertainty about tomorrow. And people also, they don't just lose their health. Sometimes they lose their faith. They lose their faith in God. They lose their faith in community. And they lose their faith, in justice. So it's actually very important. Surgery for those who are underserved is actually very important. Now, let me confess. This is part of my presentation as of yesterday. My presentation has, has evolved every day since I got here. So, actually, I had thought I would come and talk about some of the barriers that we have to accessing or providing surgery and how we can tackle them. Now that we have seen the scale of the problem and known that it's actually our God-given duty to address this, what do we do? I realized that I don't know what we can do. I don't have all the answers. As I mentioned earlier, I mentioned that people experience poverty differently. What may apply to me may not apply to another person. I had initially thought I would actually have slides prepared for each of those items there. I'm going to talk about cost. I'm going to talk about this. I'm going to talk about that. But yesterday when I was discussing with Dr. Shannon, we were talking about how people can get access to surgery and in the US and so on. And she said that the problem there is that not that they don't have hospitals around, not that if a patient needs to go to a hospital, he can't get there quickly. But some patients cannot get surgery because they have the wrong type of insurance. And I realized that in my Nigerian context, that doesn't even make sense. What are you talking about? Before they would even get a vehicle to take them to the hospital, and so on, that our problems are much different. So when I woke up this morning, I actually got up early this morning and just deleted all those slides. I said, no, I'm not going to talk about that. It would have taken too much time anyway. But let me just talk about some other things, What I believe is that whatever challenge we have, whatever barriers we see, we should try and tackle them with faith, with prayer, and with creativity. We have to be very, very creative. One of the reasons why I'm grateful that I attended the seminar, admission seminar earlier this year, and also this one, is that I get to hear stories. I'm hearing all these wonderful stories of how people are overcoming their challenges, their barriers, they're providing healthcare for people who otherwise would not have had it in very, very innovative ways. Whether it's among migrants, it's among displaced people, people in remote villages or in inner cities, people are finding ways to meet people in their situations. So rather than list these barriers one by one, let me leave you with a few principles that I thought of this morning. I just sat down and said, okay, let me leave some principles. Now, the first principle is that less is more, especially when you're creative. Now, I'm so happy that I'm the last speaker for today, the last keynote speaker. It just seems that everything people have been saying from yesterday and even today, everything just aligns with what I'm saying. So permit me to be the person who is now going to come and summarize everything that you have heard so far. So if there's some repetitions, just know that I'm just trying to summarize what you have heard. So we have to be creative sometimes. You know, we know that cost is a major barrier to surgical care. Cost for the patient, cost for the healthcare providers, and for the system. And though we are grateful for all the donations that come in and that help us with the heavy lifting, but sometimes some solutions don't have to be high-tech. They can actually be quite inexpensive. Now let me tell you a story. I'm going to talk about Dr. Whitaker now. Dr. Whitaker, forgive me. I'm going to mention your name several times during this speech. Now, many years ago, when Dr. Whitaker was working with us at the Nigerian Christian Hospital, you know, he's a trained obstetrician and gynecologist. That's what he does. But he recognized that there was this need for cataract surgery. So what did he do? He humbled himself, went up north, went for the training in cataract surgery. Then he came back down so that he can now provide this service. But what amazed me was he didn't just sit in the hospital like I would do and wait for the patients to come in. He took the surgery to the patients. He now had 2 assistants. One is a nurse. He showed how to arrange his instruments and how to assist him. The other person was just an assistant who also doubles as his driver. With those 2 people and his small, was it a pickup or a van, where he would put his equipment, he would go from village to village. He came to my village, I think 2 or 3 times. He would we would announce, anybody who can't see, please come. They would come. He would remove all patients, all people who had cataracts. He would do their surgery. Nothing fancy. Even if it's in a church, just all he needs is just a room where he can put a couch for the patient to lie down and then drop his equipment. And with that small, very, very humble setup, no fancy anesthesia, no fancy theater setting, he was able to do surgery, give out glasses, and restore sight to so many people. Another example would be something that I'm at fault sometimes, but look at something like cancer screening. We know that if we really want to screen cancer, I know there are gold standards around the world, but what if we ignore those gold standards and go back to basics? Understand? For example, a simple clinical examination can actually pick up breast cancer before the patient even realizes it. That is actually very cheap. We can do a visual inspection with acetic acid. I think that's a test that you can actually pick up cervical cancer earlier, before, if the patient cannot access the pap smear. The PSA test, these are very low cost things that can be done anywhere in our consulting rooms. And then we have also heard today the impact that comes when you have a Coke bottle, just a Coke bottle, an empty Coke bottle, and other available technologies to dress wounds. We heard today about the impact. And those things, what I like about all those stories, that they're very, very they're very low cost. It doesn't need anything. And Dr. Benskin, I just hope you know that you are an honorary surgeon just for the work you do in wounds. So nobody can tell you, how to treat a wound right now. Some of the wounds you showed us today are things that even professors of surgery have had difficulty treating. The next principle I want to talk about is, I mentioned that one of the barriers is workforce. We have workforce problems. So we need to train. We need to inspire people. We need to multiply the work. And I'm saying this now to those of us who have been in the mission for some time now. You see, as a doctor or as a nurse, it's not just enough to go to work every day if you're not handing over your skills to the next person. I spoke about this earlier in January when I spoke at the last conference, that imagine that you're running a 4x4 relay race, understand? If you like, be Usain Bolt. If you get there to the place where you're supposed to hand over the baton to and you don't hand it over, the race is over. So that's just how it is. That's how missions have endured till now. You saw that one that was built in 1965. It's still standing. Why is it still standing? Because people have taken the time to mentor people after them. Paul writes in 2 Timothy 2, Paul writes in, Paul writes in 2 Timothy 2, verse 2 that what you have heard from me in the presence of many witnesses, entrust it to faithful men who will also do what? Hand it over to, who will also teach others. Yes, that's about discipleship, but discipleship also happens in theaters too, in case we didn't know. I often say I was fortunate. In fact, I often brag, how I was fortunate to have met Dr. Farah. Dr. Farah trained me, he taught me, he showed me the way. One of my colleagues, Dr. Mesrika, used to tease me that it's like Dr. Farah laid his hands on me before he stopped coming. So I was fortunate to be mentored by people like Dr. Henry Farah, who started the hospital then, Dr. Robert Whitaker, who is here, and then many other missionary surgeons. They taught us surgery, yes. They were very committed to making sure that we know how to do these surgeries. But more than that, they taught us how to keep our hearts focused on the mission. They understood that when you now raise the next generation, the missions they will continue. So it was more important for them than just doing surgeries. What was more important for them was to make sure that they multiplied the workforce. They passed down sound principles. They showed us what excellence looked like, what precision looked like. They mentored young doctors and nurses to take up a calling in surgery. I often say that when I left medical school, I would have probably just stopped at psychiatry because psychiatry was, fun. And I thought that was probably the place I would have, been more comfortable in. But it was their mentoring that now pushed me directed me towards surgery. And I'm hoping at the end of this speech, some of you will come up to me and ask me about how to take up surgical careers. And let me encourage you all that it's not hard. It's actually quite rewarding. The third thing is the third principle is that we need to be sure that we always protect the vulnerable. Now, people who are poor are naturally vulnerable. It's not just economically, but also they're vulnerable because they're at risk of being maltreated in the very health system that they came to seek for care. They are the people who are less likely to speak up. They are the ones who are less likely to challenge you or say that they don't like that decision. Why? Because they need your help. They're seeking your help. They're also less likely to sue. Unfortunately, litigation hasn't taken up, we don't have many cases in Nigeria. And these people who can't even afford to see a doctor are not going to be able to afford a lawyer. Those lawyers they're sharks. I don't know whether they don't have conscience, the way they charge people. Now, the Bible says in Proverbs 22, verse 22, that we should not exploit the poor because they are poor. We should not crush the needy in the court, for the Lord will take up their case. You see, this is what separates us, Christian health workers, from other health workers. Dr. Lawrence, I'm going to refer back. Dr. Lawrence, for those of us who came for his lecture last night, he gave a very excellent talk on Christian ethics. So that means I really don't have to say very much. He reminded us that we must reflect the values of the kingdom when we're serving. To our faith as Christians, we should add virtue and other characteristics. And at the end, the last three ones are the ones that really struck me. We should add godliness, we should add brotherly affection, and then we should add what? Love. That means we should learn to communicate with compassion. Compassion is the theme for today. We have to learn to communicate with compassion. Every patient, even those who are uneducated, those who don't have money, they are anxious, they're overwhelmed, they deserve to understand their diagnosis. They need to understand why they need surgery. They need to understand the risk of that surgery and if there are other options. Like Dr. Shannon was demonstrating this morning, we shouldn't try to rush the patients or try to dismiss them just because we feel that they're wasting our time and just because they don't have any other option than to see us. People who are poor should not be used. I'm saying this because even me as a young surgeon, I always wanted to, try my hands at the very next procedure. Okay, let me see if I can do it now. But they should not be used as tests. Just because they have no other choice. Compassion means that we should also know our limits. And if we need help, we should seek. There was this video that was trending a few months ago in Nigeria, how a lady went to have a baby, and in the hospital she needed a cesarean section, and she died during the surgery. The husband was crying, bemoaning on YouTube, that when he was called to go inside the theater, he saw that the doctor had YouTube. He was watching a video of a CS on YouTube and trying to follow along as he did. But of course, that did not end well with that woman. But those are the kind of stories that we hear. And so in our desire to advance our surgical skills, we should do it with constraints. Now, surgical standards should not be dropped just because a patient cannot pay. Every patient requires the same amount of safety, the same amount of care as the other patient. You see, I know sometimes we have to improvise things, because of resource constraints. 3 minutes only. Wow, okay. Because of resource constraints, sometimes I have to bring out a catheter and use as a drain. But there's nothing wrong with that. But they should make sure that whatever care we're giving them, it is equal and it is appropriate. Poverty should not translate into substandard treatment. I remember once I had to caution one of my nurses who thought that she was doing a patient a favor by withholding the pain medication, because she told the patient that if I give you this medicine, it's going to cost you more money. Now, I want to mention one more thing. Our compassion must also extend to how we tell stories. Now, like I said, I wrote this down very early this morning before I even knew I was going to be presented. So in medical missions, we often like to share stories. We want to inspire people. We want to show the impact of our work. We want to try and encourage, people to donate. And there's nothing wrong with that. That is very, very helpful. But we must always ask, are we preserving this person's dignity when we're doing it? Are we honoring them, or are we exploiting them for gain? Now, why do I mention this? Because as surgeons, we are the ones who have pictures to show. I mean, the physicians hardly have things that manifest externally that they want to show everybody else. But we are the ones who want to show off tumors, deformities. There used to be a blog by a surgeon that I used to follow, but until I got tired of it, you will see people, their faces, they're in distress. You see their private areas, you see big tumors. And these images, to me, tended to strip those people of their dignity. You see, poverty does not erase privacy. It's actually very important. And people who are poor, they're not our projects. They're people. So that's why I'm very grateful that, like I said, I'm the last presenter. I'm grateful to Dr. Shannon and Dr. Benskin for showing us the example of how it should be done. How to share people's stories the right way. Their stories should be shared with consent. Number one thing. They should be anonymized, Or if the patient wants to share their story with their face, fine. There's nothing wrong with that. The stories should be told with tenderness, the way Dr. Shannon told it. Dr. Benskin said it. They should be shown with tenderness as a testimony, not as a spectacle. And I have learned so much from those stories today. Now, there's something that I used to do with my kids when we were young. In 1 Corinthians chapter 13, that talks about, lists all the things about love. Love is this, love does this, love does not do that. So when my children were very young, we expanded that list, became a list of 1,000 things, So anytime somebody does something, we'll say, okay, don't do that. Love doesn't do that, don't say that about your friend. Love doesn't do that. Don't steal your brother's meat out of the plates. Love doesn't do that. And the list goes on and on and on. So 1 Corinthians chapter 13 verse 5 says that love does not dishonor. It is not self-seeking. So when in doubt, protect the patient, not the program. And in missionary surgery, it's not just important to perform beautiful surgeries and get all the laurels for what you have done. We must also walk with integrity. Let us not hide behind the good we are doing to justify the harm that we could have prevented. And lastly, the last principle is to always pray for the patients and pray with them. Let your care include their soul. Let's speak words of hope and encouragement whenever we can. Even if the surgery cannot save their lives, at least we would have been able to save their spirits. So in conclusion, they say my time is up. Let me just conclude by thanking everybody. To those of us who serve or who are preparing to, I know many of you are preparing to come and serve with us in this healthcare mission field, we hold a very sacred trust. Whether you work with your hands, your voice as an evangelist, your voice as a singer, whether it's through your prayers or through your pen, you're all part of God's mission of hope and restoration. So every time we see a patient or every time we balance the account books, Elijah, or we preach a word of encouragement, we are bearing testimony to the compassion of Christ. In doing so, we remind the people who are sick and those who are poor that they are seen and that they are loved. They're not forgotten. So I'm deeply grateful to all the missionaries who came before us, who started these programs, all those who have donated, those who have taught, those who have volunteered. They all build a foundation upon which we continue to build upon. And their sacrifice continues to bear fruit today. So as we reflect on this privilege, let us hold fast the encouragement that comes from 1 Corinthians chapter 15, verse 58. Therefore, my dear brothers and sisters, stand firm. Let nothing move you. Always give yourselves fully to the work of the Lord, because you know that your labor in the Lord is not in vain. Thank you, and may God bless you all.
All right, thank you very much, Dr. M.M. Akpanudo. Right, let's take one question, then we can go into the breakout sessions. All right, there is someone here.
Thank you. Please, I would want to make reference to the boy with interception case that you talked about earlier. We do encounter such situations in our practice, but my issue is that you may get such a patient, staff may decide to contribute to take care of the patient. This patient will be discharged and go home and will talk to the neighbor about the fact that I went to this facility and I was treated and I was made to go without paying anything. Then another person will walk in pretending that he too doesn't have anything. So how do we deal with such situations? Thank you.
What a question. All right, Doc.
Well, sister, what you're saying is very true. Thank you for that question. It's a risk that we take. There's really nothing we can do about it. We just pray that, initially you will try and say, no, if you don't bring money, you won't get care. But eventually, compassion will take over. This story, I didn't even give you the complete picture. What happened was, after this, when we started feeding that child, the father actually came back one day. He snuck back. What did he do? He went to go and bring the siblings and brought them back to the hospital and then went back again. So we now had 3 children to feed, plus the mother and so on. So yes, it happens. That's why I said that it's actually a sacrifice. It's a commitment, but it's actually a sacrifice. We wish that sometimes we're lucky, when that happens. We may have people who are, what's the word now? Well-meaning individuals. They may just come around from time to time and just, okay, I'm going to pay this patient's bill, and that happens. This particular patient, I think that's what happened. They were in the ward for a long time, even after we had discharged them out of bed, until somebody actually now came and paid the bill, and then I took the child home, and so on. So it's just something. It's the reality of practicing in Africa. There's poverty, and people will either take advantage of it or try their best to, get what they can. Okay. But that won't stop us from doing, being compassionate the way Christ asks us to.
Thank you very much. Any more? All right, so we'll break out into the various rooms. So here in the auditorium, Kevin Lindemann will take the session on how to attract donors to help your dream project become a reality. How to attract donors to help your dream project to become a reality. It will be right here. Then in room 18, on the next floor, we have Kingsley Kelechi Na, a medical doctor and the cancer coordinator for the Nigerian Christian Hospital. He will be talking about collaborating with churches to provide breast cancer screening opportunities and challenges. And on the last floor, room 25, we have David Price. He's a graduate assistant with the African Christian Healthcare, and he'll be talking about the impact of chaplains in healthcare facilities. The impact of chaplains in the healthcare facilities. So David and then Sandra. So, all right, please come. Yeah, so room 25, you go to the very last floor. So anybody who wants to go to the very last floor, room 25, which is about the impact of chaplains in healthcare facilities, please follow him. And then Sandra, yes, so Sandra will take you to room 18 on the next floor for the breast cancer session. Then the session on donors will be here. All right. So we'll be back at 3:10. Please, let's come back at 3:10. Thank you.
My name is Kevin Linderman. I'm the Executive Director of International Healthcare Foundation, African Christian Hospitals, and our ministry has for 40 years been sponsoring a medical missions seminar here in the USA. And out of that seminar, many medical missions have started, and our own ministry has been able to expand in many countries across Africa. And I'm so excited to invite you to our first time ever hosting this medical missions seminar on the continent of Africa in Accra, in partnership with Heritage Christian University. We really hope that you're able to come and attend and be inspired, be encouraged, and to see a pathway forward in joining God in His work through medical missions. I look forward to seeing you in Accra, May 22nd through the 24th.